ರಾಜ್ ಅಂಡ್ ಇವ್ರು ಇದಾರ ಹಿರೇಮಠ್ ಸರ್ ಇದಾರ ಇಲ್ಲ no. So shall I say a few words then, because I think we should not delay in starting the program.
He's not seen me.
Yes,
Yeah,
ma'am.
he's not seen.
Yes, ma'am.
He's not seen. Yeah, I was also looking for him because I think it is very important to seek the blessings of elders when you are launching your committee work. Wishing you all the best, Dr. Raju Giraddi. You are a very accomplished sonologist at a very young age. We are all very proud of you. I think those who have joined are already familiar with your work to some extent. And today, since you are talking about basics, we all want to learn basics. So, without further ado, I think Kasoga has a great culture of sharing knowledge and sharing skill. And that is what you have set out to do. So, God bless you, and please start your program. And I think the KCOG chair, Dean is Dr. No, the KCOG chair, isn't it? Dr. Bellad has also joined. So, let him also speak a few words and then you can start.
Thank you, ma'am. Thank you so much. So I'm delighted and very honestly, pleasantly surprised to see such a good turnout despite having RCB playing tonight. So the pelvis, as we know, is the gynecologist's playground, and it's the imaging is the cornerstone of our clinical practice. So hoping today that we'll be able to learn, revise, and update ourselves regarding the same. For your benefit tonight, we have two of the stalwarts, or you can say the pioneers in the field. And I can tell that they're both excellent teachers because I've had the privilege of learning from both of them. So for starting, I'd like to introduce our chairperson for tonight. That is Dr. M.B. Bellet, sir. He is a professor, former HOD, Department of OBGYN, Kahes Jain Medical College, Belgavi. He holds fellowships from the University of Illinois, Chicago, as well as scholarships from Global Network, Division of NICHD, USA. He has been the principal investigator for many international trials, including the labor trial, preterm, cradle, clindamycin, rapid iron, and many more. Has many publications in high-index journals. He is the recipient of Newton Baba Award from both MRC London and India. And but most, I believe, his favorite award is Teacher of Teachers Award and Best Teacher Awards, which he has received multiple times. I request sir to kindly speak a few words and introduce our speaker for the evening, Raju Giraddi, sir. Thank you, sir.
Yeah. Good evening, one and all. At the outset, I thank the organizers and especially Dr. Raju Giraddi, Dr. Cesarin being our own PG, Dr. Shobha. She was a very good PG, worked and recently passed out, and now she has joined the Raichur Institute. And Dr. Raju Giraddi does not need any introduction to these people. We must have seen his videos, ultrasound videos, his diagnostic skills, his quizzes in the groups of pancreas and other group of ultrasonologists. And basically, as a very sincere undergraduate student of our college and PG from WIMS Ballari, and specialized himself in the Mediscan and fellowship in the fetal medicine. We are really proud of such of our own students coming up in their life, and we love to hear from him more than what we can speak. Raju Giraddi, you are excellent person and excellent teacher. Please go ahead with your presentation on basics in gynecologic ultrasound. On behalf of KCOG, I bring greetings to this Kasoga Imaging Committee and the chairman, Dr. Raju Giraddi, and his teammates. Thank you.
Sir, namaste. Thank you very much, sir. The very onset, with blessings from Almighty, I'm blessed to be here among my gurus and teachers, especially Bella sir is over here, and I seek your blessings, sir, and you've always been doing that. And I'm very grateful to Kasoga for giving me this opportunity to chair the imaging committee. MJ Hemant sir being the patron, and Nagraj sir. Durgadas sir being the president has given me this opportunity. Thank you, sir. I really thank others, Secretary Ma'am, Shobha Gudi Ma'am, for always encouraging me to come up with my works. Thank you so much, ma'am, always encouraging and inspiring. And and others who have joined, like Shobha Vembalgi ma'am, Ashalata ma'am, and Rajashri Paladi ma'am. Thanks for your blessings. And Bella sir being my guru since my undergraduate when I started my MBBS. So what more great honor I can have as sir has been there for me to guide all this through. Thank you so much. On behalf of the imaging committee, which is still in a cocoon form, will be coming up soon with the other programs as well. I welcome all my colleagues, especially Secretary Dr. Manjunath Ukeri, my guide and my guru. Thank you. And thank you, Cezrin, for being there with us. And she's, as sir told, she's a student of Belasar as well. And now she's working with us. Thank you, Cezrin, for the being the conducting this. So, coming to the topic, so basics of pelvic imaging, I have chosen USG as a modality. Why USG? We'll go to that. First is I bring greeting from the Betadur Hospital where I work under Dr. Jayaprakash Patil sir. He is my everything for me to whatever I'm doing. Thank you, sir, for always being there. Thank you, Kasoga. So, ultrasound. Why I have chosen ultrasound? So, because it is the most convenient and a reliable modality that one can choose, and it is easily accessible for majority and also cost effective. And most of us, we gynecologists, have this instrument to get our own diagnosis. And for example, why I have chosen USG, the reason is you could have chosen other topics as well, like CT and MRI, but definitely in this field of USG, the onus lies on the performer, as well as the same performer is going to interpret your images. So it is not just doing the scans. Say, unlike in others like CT and MRI, the radiologist may interpret only the films. But here you have to perform as well as interpret the image, and at the same time you hold the onus of being both. So that is why I have chosen USG. And of course, I don't know about CT and MRI. So gynecologists should know the basics of this. That is why I have chosen this. So we all know there are two routes that we can do. And of course, I have not included the transrectal, which is very rarely performed in our in this sector at least. So we all know about the trans abdominal approach. We have this convex probe, and the intracavitary approach, that is a transvaginal approach, that is the transvaginal sonography. So so now some basics of TVS. The first and foremost, as we all learn from the before we get into TVS, I will be sticking more onto the practical approaches of TVS rather than TAS because it is the most convenient one. And especially if you are looking into the OPDs these days, if you are looking into the OPDs these days, if you have 10 patients, I am very sure in the reproductive, most of them will be in the reproductive age group only. And there are very few who will be going for where they need only TAS. So TAS and TVS are complementary together, but I will try to take TVS a step further. Why I call TVS as better one, we'll try to know as the slides go on. Because one important thing I feel TVS is always to be a dynamic scan rather than a static scan. So that is the most important point I want to stress upon. Before going into any clinical, any examination with the TVS or TAS, we all know from undergraduate days how important is it to ask for the history and clinical examination. This plays a very important role for any examiner or a performer as he is concerned. We all will be discussing about the equipment. Definitely, we more depth into the equipment will be taken in further sessions by Dr. Okeri, who will be coming up with the equipment. I will be touching upon some parts which is necessary in TVS. And important is how to orient your the probe orientation. The image optimization is what we are going to discuss a lot today, and how to perform a systemic transvaginal sonography. So why history is important? So definitely, whenever you are doing a scan, you will always have to ask the history, because history will, after history, when you do a clinical examination, that is when you assess, you say that this patient will go for TVS rather than TAS. Because in our unit also, we always take the history and then do a PV examination. If definitely it is recommended in majority, only some contraindications we definitely are not going to do those in those populations. In some cases, we have to definitely do a PR. And why this is going to help us? It's going to guide us towards making the list shorter. And definitely when this patient comes for your screen, you will hunt for that specific pathology because you have a background behind that what exactly the consultant is looking out for. So now, when you look at the equipment, which will be discussed much later, I don't want to show the picture graph of any ultrasound. Everybody will be knowing, and you have seen that. Besides having an equipment, you should always have to know that you need to have a proper room there, and because you are going to perform either TAS or TVS, especially in these women, you need to have a privacy, and definitely among the in the private room also you should have a good changing room, and you should have accustomed, or maybe majority most of the times, an examination cot. And these things are very important. It's not just having a cot and a chair and an ultrasound machine with no proper covering and all. That is not the recommended one. We have to go for all these minute things because these play a very important role for the patient to be comfortable, and she should give the consent. Yes, I am under so and so doctor, she or he is going to take care of me. And because TVS examination itself, sometimes they feel, whenever they told TVS, and those who have not undergone, they feel that it is a bit awkward, and they say whether it is painful or they will not be knowing it. So you have to definitely take them into confidence. And if definitely if you are not a female, and it says no in ultrasound reporting, especially when I've done a TVS, one of the guidelines is they say that you have to also write the chaperone who was present apart from you who have done the scan. So having an attender is yes, I always say yes, and definitely for me it is a definite yes. You cannot do without an attender. So this is how I was telling about the cot. You can have a reclined cot with having a reclination for your limbs. You can rest your limbs, and your cot which is having a gynec cot with a cut inside, that will help for your maneuverability of the TVS probe. You can also, if you are not having this, if you have a straight cot like this, you may have to keep some pillows below, which is going to rest the below the buttocks, so that you will have to lift this. So our hands have to maneuver a lot up and down and sometimes sideways. So, and next part is the drape. This is very comfortable. This has to be make the patient to be so comfortable that she's going to help you in your examination. This is one of those cots that I have taken from Sir's Institute in Batalpalli. They have this. So now, if you look into this picture, definitely you will be able to, because I have written, you will be able to understand why is it TAS and TVS. Just a short note of it. This is the footprint view of the probe that we have, the curvilinear probe. If you look here, the TAS probe usually has a curvilinear nature, which is not almost at least 1/4 of the circle, whereas a TVS has this deep curvilinear aperture where the probe is placed. It's almost nearly reaching the half. Apart from that, you will be able to see that TAS has these are lesser frequency probes, but the penetration is more, which may reach very much deeper. And the TVS has higher frequency probes, which don't reach much deeper. For example, to show this in TAS, you will be able to appreciate whatever you have in a screen, that will be showed here. This is a uh, probe which is having 1 to 5 megahertz, and also you can see the hertz which keeps on decreasing when I increase the sector width. So, and also the depth here is measured, it is shown at what level you are looking at. So whereas in TVS you will be able to appreciate that is a high frequency probe which is mentioned here, that is the real-time intracavitary probe that you have here. And you see the frequencies in this is definitely more. And what about the sector width? The sector width in this case is definitely much greater than what you have in the, it's just it's because of the make of that probe, and also it has to go in narrow introitus as well as, and for the near structures, this is definitely going to help. I'll be taking up these things later. Yes, TAS with TVS definitely a debatable issue, but I say always it is a complementary because both have their own importance. But this is what I have taken from one of the images from the net, of course. So they have telling you that in this TAS where they are imaging the ovary, the details that was seen in TAS is very poor when compared to the TVS. So, so one of the textbooks says that in TVS, if you do, okay, in TAS, you are almost going to lose 30 to 40% of the uh, data that is there actually in the information. Sorry, the information that is going to be there in the ovary is actually lost when you do TAS. TVS is a definitely a better one, especially in the reproductive age groups, and if not contraindicated, and that should be the first choice. You should also do TAS as a complementary one, provided you're not going to lose something which is seen beyond the pelvis. So before going, now we got to know, I will be sticking more onto TVS. I would like to ask few questions to majority, some of you. Like, sometime you have done your scan, the patient scan, and you got a lesion of the ovary on one side, and you told it has to be on the right side, but intraoperative, you got it to be on the left side. Is this happened to you sometimes? Many a times this would have happened to you. Why? What would have happened? For example, I want to show you one particular case. This I have taken today only. So now tell me, I'm interested in this lesion. This is the ovary, and this lesion in the another ovary. So which side is this over? Which side is this lesion? Whether it is the left ovary or this is the right ovary. Okay, I will give you one
Left
more
ovary.
image. Some of you can type that, and Cesarin can answer me. So this is the same patient. I have done it in a few minutes or few seconds apart. You are able to see this lesion of the ovary, that is a cyst within. I don't want to make it as a hemorrhagic or a endometric. That will be different discussion. But you are able to appreciate on the screen on different sides, but it is of the same patient. So this would have happened to us most of the times because we have not got it right as a orientation. To confuse you more, what would be in this case? So you are able to appreciate a large cystic lesion on one side of the screen, and the same patient's the cystic lesion is seen in on the retrospectively on the other side of the screen. So I don't know how many of you will be able to make this out. The previous images, if you would have observed, the logos were on the same side, and this images, the logos are on the different side. Definitely both the slides are to confuse you, but we shall try to see how that is going to matter us when we do our transvaginal sonography and of course in transabdominal as well. So these are the probe orientations that I want to share. So if you look here in this, the first image, you have the logo of the machine that is there on the right side on the top. For example, this is going to correspond to my left hand or my left eye. And this is going to correspond to my right eye or the right hand on the screen. This is a reverse imaging where you have the probe marker on the down, and the screen marker is there on the lower aspect. This is reverse imaging. Some of you would have come across these images. So as per the international guidelines, there is no standard approach to say out of these four that one scores over the other. Definitely the operator can use either one of these, either the this part of the having the uterus on top and on the below. Yes, some prefer to use this. Many of the international authors are using this modality to choose. But whatever modality you want to choose, you can definitely choose, but they have their own confusions and right. But you can solve that sometimes whenever the previous operator would have operated in this fashion, you can go and change the reverse button. If you press this, the images will correspond in this way, ulta. Whereas the sideness, this is the sideness because it was on the left side of the screen here. Now it has gone to the right side of the screen. You can use this button to make that reverse flip. This is reverse imaging. This is flipping the sides. So definitely these are the buttons you can make use of it. I want to repeat it again. There's no consensus yet that this has to be followed as what you all follow in fetal medicine, where you have the transabdominal approach, where it is, I would like to stick to what we do it in our transabdominal approach, like the in fetal medicine. If I look at this uterus, I will be sticking on to my, henceforth, my images will always be corresponding to this imaging only, where I keep the bladder anteriorly and I see this uterus from the right side of the patient. As if I do my fetal medicine scan, you look this uterus from the cervix to the entirety of the corpus above, that from the right side of the patient. This is really corresponding to the superior part that I will be telling you how those apertures will correspond to. We all know this transvaginal probe. You have these spit marks for the biopsy guide actually, and this is where you place a thumb. This has to be on the superior aspect whenever you try to hold this probe. This the guidelines say that you have to keep it on top. And next, and for my imaging, I have kept my screen here with this logo onto this side, whereas this will correspond to the cranial aspect, whereas this part will correspond to the caudal aspect. So this is how I'm going to orient the images with respect to the sagittal plane. So definitely this is going to be very basics for especially for the PGs. We don't want to get wrong with our orientation on the sideness. For example, this is a transabdominal probe that I am having. You all know a probe will always have a curvature or a dip, or sometimes you also they have the marker there with the color code. So that if it is standing on this part, you are standing on this part. Okay, you will be standing here and you holding it in your right hand, and the aperture is on this part. So that will correspond on the screen wherever it is the logo of the image that will correspond to the cranial aspect of the patient. So you have the emblem of the machine, for example, that was named as GE there. So this will correspond to the cephalad, that is cranial aspect. In the similar manner, when I rotate this, see in fetal medicine, when you have the logo on this side, you have to rotate the probe towards that side. That is anti-clockwise. So this probe is rotated anti-clockwise. I want to just make a mark over here to say that this is rotated anti-clockwise. So in the anti-clockwise, the logo stands on this side. So on the screen, this is going to correspond to the right side of the patient. What you're going to see on this, which is corresponding to your left eye, the observer's eye, but this is the patient that will correspond, whatever you're going to see on the screen here, this will correspond to the right side of the patient, and this will correspond to the left side of the patient. So that is how, again, reciprocate or extrapolate that to the same TVS. Instead of placing the probe inside into the introitus, they have placed it here in oblique manner. It also has a marker on the superior aspect that will correspond to the cranial part of the uterus. And okay, when you have the marker on this side, it is our practice and it is a must that you have to rotate anti-clockwise only, so that you are going to correspond your thumb, which is there on the thumb impression, which was on the anterior part, is going to come onto the anti-clockwise towards the logo this side. So this is going to correspond to the right side of the patient. Now I'm speaking here, don't confuse with my hand. You have to rotate the probe towards wherever the logo is, and on the screen, whatever you are seeing to see the structures on this side will correspond to the right side of the patient. Right side of the patient, right, not right side of you. So definitely TVS, this is how. Try always to keep eye contact with the lady, and also try to know how, whether it is painful, because I'll be telling you how a systemic TVS scan has to be done. If you're not looking at the patient and if you're not speaking to her, you will be missing a lot of informations. Keep the patient engaged as we do it in office cystoscopy. We keep her engaged as that whenever she has pain or whether she is not comfortable, that are the things we have to look for. So that is how next is inserting the probe. I'm sticking to TVS as I have told you prior. First, explain the procedure to the lady, and that you, after entering the details of the patient in the machine, and after explaining all those things and entry of the details, you apply gel, the probe gel that is well inside the probe cover, and also a little bit on the upper part for smooth entry. And here, this is a very important part that I want to stress, that you will always have to be very gentle. You have to be gentle. If she is apprehensive when we are at the introitus, ask her to take some deep breaths, ask her to relax herself, and gently insert this probe at an angle of almost 45-degree and backwards and towards the sacrum. Stop if she says, no, it's painful. Never make an harsh effect that you're going to, no, I have to do this. You have to respect her and respect her in all manners. So, and you reassure her and tell her that this is going to be, and maybe she might come back again after some time. This is very important while before you do a transvaginal sonography. Most of us lack this. We are in a hurry to introduce the probe. We definitely getting into OBG, I realized there are definitely more pains to a woman than being a man. That is a different story. But I also always keep saying this. But this has really reciprocated on what the practice is. So now, if I go into this image, how many of you think that this image is a better one to analyze what is there? I'm not looking into the pathology, but is this a good image for to understand or to know what you're looking at? Or is this a better image? This is the same patient. This is the same patient. Okay. And there are no changes. Whatever you want to see, whenever in a photo or a pic is sent across in any of your groups, and if you try to see all these details, you'll come to know what probe is used, with what frequency it is used, what depth it is having, and what PRF they are used for the that will be very much clear in this. So no change here. Now what is that change is getting changed in this last image? Can anybody tell me? So you are able to appreciate that the same uterus now in this particular picture, we are able to see the endometrial lining much better in a triple line fashion compared to these two. And also the some contrast has gone in this. We have adjusted something. Can anybody tell me what has happened in this image? This is definitely a better image compared to these two. Okay, what I have done actually is, if you look at the first, I have reduced the taken enough depths. I have reduced the depth so that the depth reduction is come from almost yeah, from it has come to 4 centimeters now. And later I have look at this. This is the focal zone. I have shifted this focal zone at the level of the endometrial lining. These minute things we are actually lacking when we are doing TVS. These things will make the images to be brighter whenever this focal zone is at the particular line. You will be able to appreciate that the refractions from this will be much better, so that you will be able to see the line corresponding to this, and the images at that line will be much better and sharper. So that is about using your focal zones. Now we shall try to see how to optimize the image. Once you have adjusted and use your presets, apart from the machine presets, you will be making your own presets, sitting with the application engineer, because everybody looks uterus, everybody looks at the adnexa in a different manner, and whatever interest you have and what you want from it, they will help you out. These four important things I want to tell you. One is the depth, next is the focus, then is the gain, that is you adjust your brightness. That gain that it involves the 2D button as well as the TGC. Then lastly, you can always magnify and zoom. Magnification and zoom is very important. Try to use the, instead of pan zoom, the box zoom, where if you use the box zoom, you will be able to appreciate that the pixels are not lost and they're more concentrated in that particular area, and with higher frequency and with better resolution, you will be able to appreciate. Apart from that, I was trying to show you that you use your sector width sometimes in your transvaginal sonography, so that you're going to optimize the image better. So these are the presets which I use apart from the scan inbuilt presets. You can sit with the application engineer and try to have all that you hand. You can have a separate one for the ovary. You can have separate one for the 3D and all. And these are all the things that you can do. So now next, moving on to how to do this performance by looking at the probe movements. So now if you look at this probe movement, here this arrow is corresponding, saying that this is the superior part and your thumb is going to be on top. So this is going to be in and out movement. So next would be the sweeps onto the sides, onto the left and to the right. The thumb is on top. Okay, this is in sag sweep. Now this is another sweep where you are going to bring your thumb onto this side, where it's going to be anti-clockwise. In my case, it is anti-clockwise because I have told you why I'm doing that anti-clockwise. And one more is you can do the rocking movements, up and down movements. So these are the important movements that you always look for. Some basic movements, if you try to do, I'll try to show one by one. So this is the first rocking movement I will try to show you. The operator is having the hand on top of the image that I've showed you on the TVS. Here the thumb impression, the depression there. This is in the proper mid-sag position. Now he or she is scanning across the uterus after introducing into the introitus, and you are able to appreciate. Sorry, you are able to appreciate they are doing a rocking movement from the above to the below. So up down movements. The similar corresponding things we will be able to appreciate, that they are trying to get the cervix and the uterus in one plane, and they are trying to make it align, so that we are going to see the endocervical to the leading to the corpus, upper corpus. So this is the rocking movement that we need to do. Here we need not have to keep fidgeting with your hand movements. You have to be firm enough and not very hard enough. Firm enough to say that you're going to be in proper position. So this is in case of this is in case of retroverted uterus. So you are able to appreciate this part is going to correspond to what? See, now I'm able to place my probe in the posterior fornix, and this part actually where the bladder is, this is going to be the anterior part of the uterus. I hope you are getting it. See, the movements are same, but you are getting an orientation of this retroverted uterus is different from what you saw it in an anteverted uterus. The anteverted uterus was more here. The corpus was at this level. Now it is behind. So, but still the objects, the important landmarks, that is the bladder, which is anterior, it is staying there. And this is going to correspond to your anterior serosal borders. And this is going to be the posterior serosal border. So next is your sweeps. This is in sagittal sweep that you get it. The operator is moving from right side to left side. The corresponding images, these are all done it in the SAT sweep. I'm telling you, these are all in SAT sweep. I've not rotated the probe. So in the SAT sweep itself, I go on to the right side. This is the endometrial lining that you are seeing. I go on to the right side. I lose the uterus. Then I come back to the middle and I go towards the left side. So these are the very basic movements in a sagittal sweeps that you're going to assess the uterus in, maybe in adnexa also. Some of you go to the adnexa to find the ovary also. That is the same thing. But these are the initial bird's eye view to look for the uterus. Next is you have this span movements or the rocking movements on the okay, I just want to show you. Look at the operator's hands. The thumb is now rotated anti-clockwise. It is on this side of the screen. So now you are able to appreciate. Please note the movements here. They are not making any rotatory movements to locate the left ovary over here. The right ovary and the left ovary are in the same planes, you are able to appreciate. They are not making any rotatory movements. You should not do these movements, so that definitely you will get confused. The right ovary sometimes will be seen on this side. So you should be firm when you're holding your position of the on the probe, and you have to just move your wrist such that you're going to appreciate here. It is in one go. There are no rotatory movements here. For example, I have spanned across the right ovary. I go in the same fashion onto the left side. This is the left ovary. You should not rotate your probe here clockwise. You should not change it. That is against the rule what you are going to follow. It's not against the rule of consensus, but say it's against the rule of what you are following as the standard method of orientation. So this is a very, very important movement. That is what has happened in our first two images. What I did in the first, where the logo was on the same side, I have rotated the probe on this side. That is why in another image, you are able to see that the lesion of which I was trying to show you was on the opposite side. Please don't do that. This, if you try to do, you will never get confused with the sideness. And this is another video to show you. This is on the the thumb is on the anti-clockwise manner. In the transverse sweep, they are doing rock movements, up down movements that can be reciprocated here for your transverse from the cervix in the transverse view from the cervix, and you go up to the fundus. So this is going to correspond to the right side of the patient. This is the right cornu, and this is going to the left cornu. Because my logo is here, I have rotated anti-clockwise. This is corresponding to the right side. Similarly, when I go to the ovary, this ovary, I am spanning it from up down movements. In this spanning movements, I am able to count the number of follicles here. While you are counting the number of follicles in a ovary, you should never make any rotatory movements. Once you have chosen either a up down movement in the transverse, or you might also choose a sagittal movement in the side movements in the sag plane. You have to choose either one of them to count the number of follicles. So these are the very basic movements that I wanted to show you. These all will be very easy ones to answer. The positions of the uterus. If this is the vagina, and how the uterus is getting anything in correspondence to the vagina will be version, and from the cervix to the corpus will be flexion. So now this is an anteverted uterus. This is a retroverted uterus, and this is going to be the anteverted and a retroflexed uterus. This is at the level of, maybe at the level of introitus, or sometimes only at the level of fundus. It is going back, sickle shaped endometrial lining curvature. Sometimes you get this difficulty of looking into a mid position uterus. So sometimes you may also get a retroflexed anteverted uterus, which I got it today, but I couldn't add it. So these are common ones. The common ones are the antiversion, antiverted, antiflex uterus, retroverted, retroflex uterus. These two are very good for our imaging, believe me, because I'll be coming to that. Now this is a uterus, a peculiar uterus where I can ask somebody to please stop these annotations on the screen. Please don't do that. So now you are able to appreciate this endocervical lining in continuous with the corpus is showing a kind of curvature as if you see a question mark over here. So this is a kind of a question mark sign, and you see some haziness, that is salt pepper appearance in the posterior part. This uterus is definitely telling me there is some pathology in the posterior aspect. This is going to tell me that there is some adhesion over here, so the fundus is getting pulled. So that is why you are getting these orientations. This can also be seen in case of a previous LSS when you have a niche over here, but in that case you may not find adhesions posteriorly, but the angulation will be too sharp at the level of the scar area. So once you have known your scan movements and the orientations, now we shall try to see how to do a systemic scan. See, actually, hysteroscope is a misnomer. Hysteroscope is a misnomer. Why? Because it's not only examining the uterus, but in hysteroscope, we always start from the introitus. But we being sonographers, we are not doing it from the introitus. The very essence of transvaginal sonography begins from the introitus. Most of us only go and hit at the uterus, and that too, we only span across the corpus, losing the cervix and also the vagina, and also in some part in the anterior compartment, the posterior compartments. We only believe or think it's only the corpus and the ovaries that has to be screened. If you are trying to do that, we are going to miss all this. It has to begin from the introitus, from the vagina. Then you also try to know where the urethra and the bladder, how they are aligned. Then you go and hit the cervix, try to assess the cervix, then go into the uterus. Then in the uterus, you try to compare all those or all structures that you have, the endometrium, the myometrium, then you go into the adnexa to look for the ovaries, look into the anterior part also, and then come to the POD. Most importantly, why I call TVS as a very important scan is because we look for the sliding signs. That is why it is called as a dynamic scan. We also try to know how these are getting aligned or how these are getting related with each other. So now when you're trying to see, I just want to pause over here before I could start. This is the systemic transvaginal scan that we all must be doing. I just want to come back. Okay. So look at the probe. I have kept the probe at the level of introitus. You are able to appreciate the anteriorly. This is the bladder. My voice is clear, ma'am, and the videos are clear. I have not asked till now, though I have moved many pages. Sorry.
Fantastic.
Yes, sir, clear.
Sorry, ma'am. Thank you. So now I have kept my probe at the introitus, and if you are able to understand my orientation over here, this is just at the introitus. I've just moved inside. This is going to be the bladder, and this echo of the anechogenicity is the urethra. You should try to define this. And this is the bowel posteriorly, the rectum. So your movement should be so gentle and gentle and proficient and slowly that you're going to do it in a systemic manner like this. So I go slowly into the introitus and try to assess the bladder and the urethra over there. Then I take my probe into the posterior, towards the sacrum, and I try to hit the anterior fornix. So now once I have hit the anterior fornix, I want to show you that I have been able to image the cervix and I have taken enough depth so that the region of interest, that is the uterus, is covering almost 75 to 80% of the screen. I take my focal zones at the level of the endometrium lining later. Now I have made the rocking movements to get the uterus and the cervix in one plane. Now I have taken enough depths. Now I have adjusted the focal zone. Now I have taken the focus as well. Now I am taking the right sagittal sweep where I have gone to the right side. Then I come back to the middle. And this is the sagittal lateral sweeps. And then I go to the left side and I get. So this is my SAG sweeps. Okay, then what I do, I rotate the probe anti-clockwise because this side is going to correspond for this as the right side of the image and this side is left. Now I have gone towards, I'll be going now. This is at the level of fundus. This is a transverse sweep that I'm trying to show you from up-down movements. Now I'm going towards the cervix. These are the Nabothian cysts that you see. I go towards the cervix. Then again, I come back cephalad, that is towards the corpus. Now, as I go and I try to see this playing of the endometrial lining at the level of fundus. So this is my initial sweep to understand how the cervix and the corpus is in whole as a uterus, apart from looking into the vagina. And I have noted that this uterus is in the anteverted anteflex position. And one more important thing I wanted to show you, I have kept my sector width almost 180 degrees, so that I want to see the uterus as a whole. Though the resolutions would have been less at the lateral aspect, but definitely I wanted to know as a whole. This is the bird's eye view. Then next I will be going for the adnexa. So now in adnexa, what I have done, I have reduced my sector width to some extent, and you can follow that, so that because I'm not interested in the other lateral aspects apart from the ovaries and other things. So I will cut short those so that my frequency will go and my frequency will reach high and my resolution will be better. So in adnexa, I am looking at the ovary. This is the right ovary, and I will still reduce that to get ovary, and the focal zone is at the center here. So one ovary is occupying almost 70% of the screen, and I do the movements of up down movements to count the number of follicles, and I go and reach the uterus in middle. That was on the right ovary. Then I go towards the left ovary without rotating my probes. I have moved my probes from right side to left side without rotating the probes, and I have localized the ovary in the adnexa. Next, I'll come back and increase my sector width. I want to see the uterus as a whole again. Now is the important steps that I want to do. That is the sliding signs. I'm trying to place my probe in between the uterus and the ovary and trying to give a push in between them. You are able to appreciate that the ovary is moving in one axis. This is that was on the right side. This is the left side. The ovary is moving in one axis and the uterus is moving in other axis. You are able to appreciate the echoes of the bowel that are in between. Sometimes it's the momentum also. So it is how we need to look for the sliding sign. That was the sliding sign. Then I keep my probe in the anterior fornix and trying to look for the sliding signs of the POD. You are able to appreciate the uterus is moving in the cephalad axis and the bowel is getting pushed in the posterior aspect and it is moving easily. Now, lastly, I also look into the anterior pouch vesicle fold. This is the anterior compartment. This is the bladder. You are able to appreciate the vesicle fold is also moving easily. So this is to tell me that this approach is telling me that there is no adhesions likely. There are no adhesions. The last part I'm going to skip because now I have taken my probe with decreasing my depth. I've taken my probe in the posterior fornix. This I will be discussing when we take up on understanding deep infiltrating endometriosis, where I try to locate for the uterosacral. So this is on the right side, and we do it for almost everybody, especially in the infertility age group, to look for any deep infiltrating endometriosis. If you ask me, the most common site for endometriosis is this is on the left side. This technique I will be explaining sometime later. The most common site is the uterosacral. It is not the ovary. So I want to show it again. I just want to show it again. So this is the fundus. I am following this band-like structure in my transverse sweep only to get the ovary. So this is the way I locate the ovary in my transverse sweep. There's nothing wrong in locating in sagittal sweep as well, where you'll find the borders here on the lateral aspect. That will be the iliac veins. That is the extreme extent. Then before that, you'll get the ovary. So this is my transverse sweep onto the right side. This is the uterus. I got it in between, in middle, and the left ovary is very close in relation to the uterus. So this is the left ovary. So that is a repetition. Now, what is that I'm trying to show you in this case? See, when my sector width is less, I am losing a lot of information. We don't see at the cervix at all. So I will be trying to show you how to look for, these are the very simple and basic movements that we need to see so that we are going to not miss any pathologies that the uterus is going to have. I've increased my sector width so that I want to get the cervix in plane and the uterus at the corpus in one plane, reduce my depth. I've reduced my depth and taken my focal zones at the level of the endometrium. And now I'm trying to see that the uterus, how are we going to measure this? This is the external os. This is the endocervical canal, and this is the endometrium. So I got the uterus in one plane, making sure that the endometrial stripe and the cervical canal stripe is in one plane. For a normal, this is actually a normal uterus. You may always not get this in pathological uterus. That is the axis deviated uterus. That is what you have to call. We will be taking those cases later. But in a normal case, how to measure? So once I have got this in proper mid-sag, I will start using my calipers. I use the 2-point method. Instead of taking a straight line from here, every machine will be having a 2-point method. We can begin from the serosa on the fundus, go along the endocavitary lining, mark the points wherever it is getting curved. You can press and start, you can press and start up to the external os. And also the widest part has to be measured as the width. This was the length, this was the width, that's the height. Then this is going to be the width. In the transverse sweep, I may reduce the sector width to know the delineations better, or yes, and then you go and try to take the measurement wherever this endometrial lining is trying to get splayed at the level of fundus. That is going to be the largest width that you're going to have, the plane of largest width. So this is going to give me the volume of the uterus as well. Now I'm coming back to locate the endometrial lining and how to measure the endometrium. So I will reduce the sector width and try to focus more on the endometrium. You may not use the box zoom here, but just to highlight that I have to the importance of knowing for more frequencies and trying to locate the pathologies within the endometrium, you may use this. This is a very thin endometrium because she was in menstrual phase. So this is for demonstration purpose. So that in this way, you need to measure your uterine measurements. Now I've gone to the adnexa to look for the ovary. What I do when I get the ovary? Once you have got the ovary, reduce the sector width so that your resolution is going to be better. You can change the presets as ovary. I have changed it for my own presets as ovary because they have a bit of more contrast for the cystic lesions. And now you are able to appreciate. I'm trying to count the number of follicles in one go from up down movements only. I'm not rotating the probes sideways because that will overcount the follicles. You may use box zoom over here to make it magnified, and always take always any cystic structure including the ovary, try to take in a split screen to measure. Always use a split screen, and whichever is going to be the largest longitudinal plane, that plane has to be freezed first. Close your eyes, then rotate exactly 90 degrees to that movement. You will get the corresponding orthogonal plane. You may not have to find the largest plane here again. I repeat, you look for the largest longitudinal plane in the first go, freeze it. From there, you rotate the probe clockwise or anti-clockwise. It's okay because you're in the same ovary, and be that you're going to be 90 degrees to that, and that is the orthogonal plane. So if you don't have the calculation, if you don't use that, length, height, and width, then you have the calculation factor as 0.5 to look for the volume of the ovary. So you have this button in the machine of using the box zoom. So some more importance to show of the importance of doing a sliding sign here. You have an hemorrhagic cyst on the right side. See how freely it is moving. So this is on the POD. This is the cervix. It is retroverted here. So you are able to appreciate in the POD there is bit free fluid and it is easily sliding. The bowels are easily sliding against the serosal surface. This is to show that this is positive sliding sign. If you get an adhesion and if you don't find the sliding movements, it is negative sliding sign. So we are grateful to Timor Stitch who has given this sliding signs. And this is how we look for, we just don't look into the uterus, we just don't look into the ovaries. We also look for the adnexa and how they are related with each other and how they are sliding against each other. This is an easy sliding sign that you see in the posterior aspect. So what about this? We all know pathologists will describe later, but pathological cystic lesion on the right ovary, but it has got stuck to the uterus serosal surface over here. It is not moving with your probe movements when you're trying to push it aside from the serosal borders. So you're able to appreciate, I'm trying to push the probe in between these two. You are able to appreciate both the ovaries are in close approximation to the ovary, a classical feature of negative sliding sign in case of endometriosis. Yet another case to show where both the ovaries are in the posterior serosal surface of the upper corpus of the uterus. You are able to appreciate that they are not moving. They are moving as an entire complex. They are not sliding against each other. In the posterior aspect, when you try to find, the bowel is not moving against this. This is the posterior lip of cervix. The anterior lip of cervix is the bowel. So yeah, it's not moving against the uterus. So these things, that is why they're important. When you are trying to do these signs, these are actually the soft markers we call it. When you look at the patient, they will have enough pain. I request everyone to look into this paper, though it is of endometriosis paper, but this is what a kind of breakthrough that we had in endometriosis imaging. But that also plays a very important important paper for all of us to do, how to do a systemic transvaginal sonography. If you try to follow this methods, you will be able to appreciate that you should not use only your one hand for a TVS. You should also try to use your other hand. If you are a left hand, whatever it is, the other hand has to be on the abdomen also to look for the sliding signs. So as I've told you, there are some soft markers. Look for the site-specific tenderness and ovarian mobilities, and also look for the POD where the ultrasound-based sliding sign can be assessed, and look for the DIE nodules in the anterior and posterior compartments. These are the important steps that this paper has. This paper also has down videos to download. Please read it. And then how important is to do a transvaginal sonography, we'll come to know. Based on that paper, if I try to show you, I will try to show you what I'm trying to show in this. A previous LSS case, one scar area, another scar here. I'm able to appreciate the uterus is in close, in the anteverted fashion only. But what is that I'm trying to show you? Sorry. Okay, what I'm trying to show you. See, I have assessed the uterus. I'm using my left hand and trying to push at the level of the scar area. That movement is getting transmitted to the anterior aspect of the uterus. Now, better than that, I will try to pick the pannus of that scar area or the skin fold of the scar area and try to pull. You are able to appreciate that this uterus is getting moved in the direction that I am trying to move it. So this is to show that there is adhesion of this uterus in the anterior corpus. So most likely it was on the left side. We'll try to see the corresponding laparoscopic approach in that. So this patient had severe chronic pain. And when we look into the laparoscopy, you are able to appreciate the uterus has got hanged to the anterior abdominal wall. And these are the movements that you do in your TVS. You are able to appreciate that this uterus was actually hanging onto the scar area and the upper part of it as well. Though it was free onto the right side, but definitely you are able to appreciate that this is a uterus. We call it as the lizard uterus or whatever. It is Dr. Jayaprakash Patil sir here who's doing the adhesive in this case. So this is how our systemic transvaginal sonography is going to help us in knowing all these entities. Sometimes after looking the ovary, we have to span a bit across up and below, side and side, above and below the ovary as well. You might find another cystic structure in close relation to that. Many of you would have got it, but definitely you would not have really made this so proper in your TAS because I am trying to do a split sign over here or a sliding sign to say that I'm trying to push my probe in between this cyst and the ovary. You are able to appreciate that my probe is going in between and the ovary is moving and the cyst is moving. They are moving far away. So this is a para-ovarian cyst. So this is how a TVS definitely helps in knowing all these things. So I'll try to show you some more cases where you will be able to appreciate how a TVS is going to score the other areas. So this is, I'll skip it. Okay. Now, what do you think I have done in this case? Initially, when we all thought, although my sector width is more, I tried to see the cervix as well, the corpus as well, but I was actually wrong. I didn't do my TVS in a proper manner right from the introitus, because if I would have done that, I would not have lost this information, which is echogenic tongue-like lesion which is protruding out through the anterior and the posterior lips in between this in the cervical canal coming out at the external os. So what do you think it is? An hyperechogenic line which is having a stalk-like lesion which is coming out from right from the cervical canal out into the outside world, that is the external os. So always in gynec, I request that whatever you do, you don't have any confrontations. You please put Doppler. If it is a non-pregnant uterus, play with your colors, always play with your colors, and you will get a lot of information. In this case, if I try to put a color, you will be able to appreciate that this, yeah. Once you try to put the color, you are able to appreciate that this lesion is actually coming from the lower corpus, and that will tell you the extent of, I missed, okay, that was the, sorry. Okay. So I really missed the color part over here, but definitely the color going to tell me from where this lesion is coming. So this is how, if you try to place your color, and also when you do a systemic scan, you will not miss the cervical pathologies. So this was a cervical polyp. that was there. And this is in how it looks in half-face hysteroscopy. It was a pedunculated polyp that was coming from the lower corpus, and endometrial polyp that is pedunculated. So this is a questionnaire to most of you, for all of you. This is the bladder. I want to tell you, this is the bladder. These are two cystic lesions in the ovary. So how many of you think these are just two simple cystic lesions? I'm telling you, this is the bladder. These are the two cystic lesions of the ovary that are seen. So now why am I trying to show this images is that any cystic lesion in the pelvis has always to be compared with the bladder echoes. You have to play with your gain settings, especially the 2D button what you have. And once you try to play with your 2D button, you try to make this bladder to be in such a manner it has to stay anechoic, and then make adjustments to look into the internal echoes of this. So you will be able to appreciate when I'm trying to keep this as anechoic, that was because I had increased my gain. Now when I tried decreasing it, that you will be able to appreciate that there are low level internal echoes in this. So it is a case of endometriomas. Very often we come across these things when your gain settings is not proper. So gain settings do play a very important role. Some important things to tell you about cystic structures: always compare with the echoes that you have with the bladder, so that you are going to keep it anechoic to the optimized gain. I don't say it will be anechoic even in low gain and high gain. So the optimized such that you are going to appreciate the difference in these two. And always any cystic structure in the pelvis, try to measure it in three orthogonal planes, even if it is a follicle. So this part, okay, that is again to show the comparison of the bladder and the cyst. This was a serous cyst here for the just of a comparison. So this is all about a simple TVS examination, but still history and clinical examination do play a very important role. TVS and TAS, they have their uh, own importance. Privacy and consent is important. You have to be very gentle, optimize your settings, use your other hand. I don't say left hand. Now, if I'm trying to do my ultrasound in my left hand, then I have to use my right hand on the hypochondrium. Then important, always do the sliding signs. Don't accept a report, a pelvic scan report, especially when you're screening for infertility purpose. Don't accept a report that they have not mentioned the sliding signs of the adnexa. So I don't want to put down any TAs also, because that was the internet image. Now, if you try to see with good frequency probes as well, this is what I'm trying to see in a lady for whom TVS was not possible. So a young girl, unmarried, and she didn't, okay. But still, now I've reduced the sector width so that the frequency goes up. Now I've taken the box zoom. You can still see here, this frequency goes up more. And apart from that, it goes up more, and you are able to appreciate this uterus in a very optimized way that a ultrasound in a transabdominal route can give us. You can appreciate the triple line of the endometrial lining. You can also appreciate the cervical lining, and apart from that, you will be going to into the adnexa as well to look into the ovarian pathologies. Yes, but if the ovaries are not large, if the lesion is not large, not going above the pelvis brim, yes, if there is no contraindication for TVS, subject this lady also for TVS. So, okay, that would be much better than what you get. For example, if you look into this image, sometimes you have a lot of difficulties in your TVS where the uterus stays mid-positioned. You are not able to appreciate the echoes of the endometrial lining. The beams are staying parallel rather than perpendicular to this endometrial lining. Though once I reduce the frequency also, you are not able to appreciate much better, but you are able to appreciate some serosal borders here or here. But when I subject her for such cases for ultrasound, for TAS, you might gain some confidence that, okay, there is no definitive endometrial pathology. This is getting aligned along the posterior border of the bladder, though I have not filled it too fast because too high, but for me to pick up this information was more than sufficient. So out of these two, I want to stress, we all apply probe covers and apply gel below that, but which of this is aptly applied? If you look here, there are some air gaps or air gap over here in this probe cover. Definitely this will hamper your near vision, especially when you're looking at the cervix and the urethra. Such lesions will not be well defined. You might lose a polyp because this will cause you some artifacts. When it is snugly fit and there is no air gaps or no air halos, then definitely this is a this is a good one. So as I told you, always play with colors. I don't want to go into the pathologies now. We all know it is a polyp. Anything, any damn thing, you always try to put colors. Once you put colors, you will be able to appreciate that. See, always one more thing I want to stress. I didn't make a slide of that, but I'm very sorry for that. Colors will be taken up when we take up infertility aspect or any other aspect on RPOC and all. Always keep your PRF, pulse repetitive frequency, at zero point 0.3 and wall motion filter at low. It can be low 1 or low 2. Always keep it at, because these are all low vessels. If this would have been at 1.8 or 2 point more than 2, definitely the feeder vessel in this polyp would not have been picked. You might find a pathological lesion in grayscale, but definitely when your PRF settings are not good, it is not going to pick that feeder vessel. So now what I'm going to tell you in pelvis is that be it in the uterus, be it in the adnexa, play with your colors at the PRF settings of zero point 0.3, maximum at zero point 0.6, and wall motion filter at uh, low. So how do you get those? You can use it manually by looking on the probe settings, but you can ask your application engineer to get those presets. In all my gynec settings, I have this PRF of zero point 0.3. So that is how we can do it. You have the PRF button over here. This is the scale that you have. It is kept at zero point 0.3, and the wall motion filters these buttons. And also when you look at somebody who has sent you an image, you will get the information over there. Why this, though there was a lesion in the endometrium, why it didn't pick the feeder vessel? Maybe they would have wrong settings of PRF. You can correct them and help them. So some important points: assess the uterus TVS preferably. If there is no contraindication, definitely. In some cases, you may have to do transrectal also, but that requires a lot of image optimization, because that is different, and also it will be a bit painful also. Confirm the orientation of the uterus first. The panoramic assessment has to be thorough, and assessment should be both in longitudinal as well as in transverse. Endometrial status to be always correlated with physiology. For example, today if the lady, that is why history is very important. If a lady comes at day 9, day 10, the corresponding dominant follicle will be seen in the adnexa, that is in the ovaries. So you cannot tell there is a cyst inside. At the 14th day, a follicle may go up to 24, sometimes 25 also. You may have to call it as a follicle, not a cyst. So that is how you, in the secretory phase, you will expect to have a corpus luteum. So that is how you always have to correlate. And always don't forget the cervix, and the color. Of course, I have missed the color, though these are all in colors. I am sorry for that. You should play with your colors. I thank Jayaprakash Patil sir for giving me this opportunity, and he's the driving force for me to everything, because my learning in ultrasound is purely retrospective. So I would like to take some questions if any are there. This is all that I want to share in basic scans. Thank you, sir.
Uh, at the outset, Raju, it was an
Sir.
excellent demonstration come presentation. You really covered very important practical points, and it is an eye opener for many of the sonologists that how important the sliding signs are and how to go about looking at the pelvic organs and how to use the probe. Very basic but very fantastic presentation. I congratulate from
Thank you, sir.
the SUOG and Kasoga team for this demonstration. I hope all the audience enjoyed this, and thank you for that wonderful presentation.
Sir, thank you. Thank you so much, sir. Thank you, sir.
Fantastic, Raju.
Sir, thank you,
Very
ma'am.
nice. Very nice.
Thank you, ma'am.
Sir, shall we take a few questions from the audience?
Yes, ma'am.
They're quite active in the chat box, very interactive throughout your session. Many people want to know, sir, how do you adjust the sector width? I believe it's a technical question, sir.
Yeah, all machine have the button for that particularly. It may be a button which is going to up and down movements, or it is a round ball like. Some machines call that as field of vision. So G call it as the width, acquisition width. So you can definitely increase that. You can definitely increase it, but it has its own limitations. The pixels will come down, And when you are not interested in looking the regions apart from the region of interest, please don't increase the sector width. You may have to come, for example, in early gestation, when you find a gestational sac or a ring, when you want to define that properly, you may have to reduce the sector width and also use the box zoom to define it better, so that you will try to see the decidual reactions, or whatever you would like to see. So that is how it is. Every machine has, any basic machine has that.
Thank you, sir. Sir, another Ashish Panchal, they want to know if cystic lesion in the ovary has internal echoes and reticular pattern. How should we call it, and what is the size cutoff to call it as a cyst?
Yeah, this we will be covering in the adnexa and the cystic lesions definitely. But for the basic understanding, why I have to touched upon a cyst lesion is that we would always have to compare that cystic lesion with the bladder first thing, and internal echoes have to be understood only when you have proper gain settings. And reticular fibrin like strand, what you have explained, it is going to be an hemorrhagic cyst, even whatever may be the size. Sometimes it may be smaller one which is regressing. And cyst, as of course a dominant follicular cyst, I may consider it up to 3 mm. But if you want to call it as a benign cystic lesion, I will take it up to up to 4 centimeters. But above that, you have to definitely think in terms of any cyst adenomas, or because that will take us to another understanding pathologies we will be covering in our future sessions.
Sir, one more, sir. In a mid-position uterus, how to see the sagittal section of uterus?
That is what I showed you one difficulty. See, always I want to make it very clear. The presenter who presents always takes the good images for presenting. So that is one disclaimer I want to tell. Definitely, all of us will be having difficulties in understanding the positioning of the some abnormal positions that the uterus will be having. One of the hints I would try to tell you, you try to place the probe either firmly into the anterior. I know the patient might have some pain or discomfort. You have the fornices made for that. The TVS probe is actually made and go and sit in the fornice. You try to place the probe and try to give some jerk or movement. You might align the uterus in anteverted or retroverted fashion. If at all sometimes you can make it, you try to press it with your other hand, get into the hypochondrium. If it is a large uterus, definitely if you push a lot, you will be able to get that uterus in one of the directions. But yes, especially in postmenopausal and perimenopausal age group, when the uterus is standing in midline, as I have shown in one of the cases, there the beams are actually parallel to the echoes, parallel to the endometrial linings. You will find difficulties in understanding the endometrial pathologies. So that time, lucky enough that if you don't have adhesions or previous scars, try to get that uterus in TAS with full bladder and with good resolution probe. You might definitely get what you wanted. It is difficult, sir. The best uterus I would feel is always a properly antiverted antiflex uterus, or a retroverted retroflex uterus. Mid position uterus, lot of gray areas. Yeah.
Thank you, sir. I believe we'll call this session to an end. If
Yeah.
Dr. M.B. Bellet, sir, will speak a few words as closing remarks.
Yeah, I I
Sir.
think it was a wonderful program. Raju, you
Sir.
made this, great beginning of
Sir,
your
thank you.
committee. I think in the days to come, this will further enhance the quality of
Yes, sir.
ultrasound. What as a gynecologist we are doing it, and also it will improve that how we should report it, and it may also assist in suspecting in laparoscopy if there is
Yes,
or
sir.
laparoscopy planned procedures. Excellent presentation.
Sir,
And
thank you.
Master of Ceremony also, I must thank Cesarin. You have done a great work, and all the Kasogians who joined, also the KCOG team. Thank you all,
Thank
and
you so much, sir.
thank you,
For your
thank
blessings.
Thank you.
you,
Thank you so
Raj.
much, sir.
I know that this is the beginning. Still, there's a lot to be learned and shared. The members who have watched it, maybe they might get access through the YouTube channel. So please share in what ways that we can improve, so that we may try to fix those problems and also come up with some other ideas so that we can try try to share in a better modality. So always in futures will be like more of laparoscopic and ultrasound correlations, and that is how we would like to take up, because that is how we need to learn. And maybe and any other suggestions are always welcome. Please post it in YouTube channel, any of your friends, or through the society groups, and into so that it will reach me in one or the other ways into the Kosaga group. Thank you.
Yeah, I think Ashalata, the EC member who is there, I think can she add few comments if or Shobha Gudi is there.
Ma'am.
Hello, sir. I'm Dr. Ashalata.
Namaste, ma'am. Namaste, ma'am.
Yesterday, when Raju sir sent me, I said I'll definitely join. And it was fantastic and basics. Every person need to know how to do the basic scans, and it was very wonderful program, sir, today. So wish
Thank
you
you,
all
ma'am.
the best to continue the same in the near future.
Thank you so much, ma'am. Thank you, ma'am.
I'd like to thank